Objectives for today are to understand the basic definition of spasticity, understand the basic mechanisms of what causes spasticity, utilize different measurement scales to measure, and then identify some different treatment options for patients with spasticity. And lastly, identify your role as an OT or PT in the management of spasticity with MS. I can't tell with most of you if you're OTs or PTs, so I'm just going to speak to both. Okay, first of all, what is spasticity? There's been a lot of mixed information and different definitions of spasticity that have been floated around over the years. But the true definition, the medical definition, is a velocity-dependent increase in tonic stretch reflexes of a muscle due to the lack of inhibition from upper motor neurons. And that's the official definition at this time. So you do have to have upper motor neuron involvement to have spasticity, which differentiates it from some other stiffness and tightness that you'll see in people with other peripheral neuropathies, some other demyelinating diseases that affect the lower motor nervous system. And spasticity also causes an increase in contraction, or what we call, I guess I can't finger quote, tone over the years in muscles, and hyperreflexia. Oh, I'm supposed to move my mic away from my mouth. Okay, is that better, Kelly? I guess you guys were getting some feedback, sorry. The biggest thing is that because this is an upper motor neuron problem, there's a lack of GABA inhibition. If we go back to your neuroanatomy, neurophysiology, what's lacking is an inhibitory process to stop the muscles from being active, and that is basically done by the transmission of GABA. So any injury of the central nervous system or an upper motor neuron can cause spasticity. This can be MS, this can be a higher level spinal cord injury, usually T10 or above. This can be a CVA, this can be a traumatic brain injury, this can be cerebral palsy, this can be an encephalitis. So anytime you're getting damage to the brain or spinal cord above about the level of T10, you are going to have potential issues with spasticity because that inhibitory process is interrupted. Okay, this is a basic example of spasticity where I'm going to talk through this in a way and let this download for just a second. Sorry. This is a gentleman, and you can see that as you move him slowly through the motion, I'm going to play this a couple of times as I'm talking, he moves pretty well, and he has pretty good range of motion. But then you notice when I give him a quick stretch, he almost even starts to get a little clonus, and you can see how his range of motion continues to decrease and decrease and decrease. So we'll watch that one more time here. Okay, and we'll get to see this gentleman a little bit more in function in a bit. So that's what you'll see for spasticity, and this is a pretty typical ankle joint right here that you can see, but you will see this in knee extensors, knee flexors. You can see this also in upper extremities as well. So really any joint that is below the lesion level. So in a stroke or MS, if it's in the brain, you can see it anywhere below the brain. In a spinal cord injury, you would see it below the level of injury. Okay, there we go. Okay, is spasticity a problem with MS? This is where it gets a little bit tricky sometimes. 84% of individuals with the MS report some spasticity. 17% report that it affects activities. 13% are forced to modify daily activities. 4% report that it prevents daily activities. The biggest complaint with MS and spasticity is the reports of pain. We will look as spasticity gets more severe, how to look at some case studies and see what's a problem as far as their spasticity goes and what's helpful with spasticity. Occasionally spasticity can help a patient be more functional. Problems with spasticity, as I already mentioned, pain is a big one, either directly from the muscles that are overactive or from compensatory strategies because they walk funny. They may have increased hip abduction and circumduction that can cause back pain, or they may have postural problems if they have a lot of upper extremity flexion that may be pulling on their brachial plexus or causing more tension in their neck. Also decreased range of motion. This can either be temporary, as in the gentleman we just saw, or it can be due to a contracture. If spasticity is long-standing and the patients can't move through a complete range of motion, they may develop contractures. There can be circulatory problems because the muscles are not contracting and relaxing in a normal pattern. We all know that our circulatory system needs muscle pumps in the extremities, so when you lose that muscle pumping action, you can have circulatory problems. And then changes in posture long term. We see this with individuals that have been spastic with severe spasticity, sometimes for a very short period of time, but we definitely see this over long periods of time with individuals that have spasticity. Secondary problems. Decreased mobility. Decreased walking is one of the biggest complaints in our patients with MS and our patients with CVAs and truly our spinal cord injured population as well. So decreased mobility is a big one. Decreased function and independence, especially with upper extremity spasticity. When the hand becomes more in a fisted position, it becomes very difficult to use it, and function can be greatly affected by that. Decubitus ulcers, anyone that works with people that are stationary for long periods of time or works in long-term care can have lots of first-hand experience with this, that spasticity and poor positioning causing lots of problems with decubitus ulcers. Decreased overall health and well-being. This is kind of the sequelae of the decreased mobility. I'm off camera. Decreased mobility, so you have decreased overall health and well-being, so you are less mobile and you tend to cycle and cycle and cycle. And thus causing increased caregiver burden. I didn't put on here another tertiary effect is increased healthcare costs with all of these other issues that are going on. How is spasticity measured? This has kind of been very nebulous. People have increased tone, they have spasticity, but it's been very kind of gray as far as how to measure it. And even the best measurements are still somewhat subjective. So it often helps to have two people measure or to videotape, I found. One of the best, most common ways in adults is the modified Ashworth scale. There's the Tardieu measurement. Please pardon my French, or Tardieu. I've heard some people pronounce it. There's general reflex testing, which we've all done. There's functional testing. The modified Ashworth scale, originally there wasn't Ashworth, now they've modified it and they've added this 1+, which again is a very subjective sort of measurement. It is pretty universally accepted though in the areas of disability and spasticity. It has good inner rater reliability. So if I measure it over and over and over again on my patients, I will continue to measure them the same because I'm interpreting the scale and how the feeling's the same, kind of like manual muscle testing. But if one of my colleagues goes and measures the spasticity, it gets a little fuzzier. It only has fair inter-rater reliability. So myself measuring my own measurements, my own patients over and over and over again it's going to be very consistent. If my patients then go to the physician and the physician measures it, there could be more variability there. And I apologize for this slide. It looked fabulous on my screen. It's not looking so fabulous on this screen. if you need me to, if you email me, I also can send you a direct link. This is the Modified Ashworth scale. It talks about, it's on a 0 to 4 scale, so you have to be careful when writing it because we're so in the habit of 0 to 5 with our strength testing. 0 is normal muscle tone or no muscle tone, so when a person is relaxed, you can move them completely through the range. 1 is a very slight increase in muscle tone, which is just kind of a little bit of just a little catch in there that you can just easily catch and keep going. 1 plus is a slight increase with there's a catch and then a little bit of resistance, but you can still get easily through the range. So it's easy catch, a little harder, but can get through the range. 2 is a marked increase, so as you're moving through, it's tough, but you can get through the whole range. 3 is, man, you are cranking on that to try to get to end range. If you quick stretch, you definitely can't get there. And a 4 is pretty much rigid, and I know we've all run into a few 4s, especially in the ankle. So that is the Modified Ashworth scale. Again, it's subjective. It's like strength testing, you know, and it takes practice to kind of feel different people with tone. So take that out there and play with it. Pros and cons of the Ashworth. Pros, it's easy. It's quick. You saw me do it, you know, a couple of times on that foot earlier. It's very inexpensive, obviously, and it's very widely used. If you look in the spasticity literature, this is pretty much the go-to measurement for spasticity. So that's what they're all using. Cons, again, it's inconsistent between raters. Even within our own office, I can measure once, the PA or the physician can come in and measure, and we're going to grade it a little bit differently, especially down at the lower end, the 1 pluses, the difference between a 1 plus and a 2 sometimes, or a 1 and a 1 plus. It's also very difficult to tell the difference in contracture versus severe spasticity at a grade 4. A lot of times I think someone has a contracture and then we do another intervention and it turns out it's just spasticity. So it's really hard to tell at the very low ends of the scale and then the very high ends. And often for people that aren't familiar with spasticity, spasticity can be confused with strength. Just because the patient's holding, they're holding, they're rigid. So is it strength, is it spasticity? And again, some people will read the Modified Ashworth if it's not clearly marked that it's a Modified Ashworth, and they'll confuse it with a strength grade. So you do have to be careful and make sure that it's well marketed, that it's in your evaluations, that it's not strength. You're measuring spasticity in this portion of the eval, because they're going to see, oh, 3 of 4 strength, that must be pretty good. And you're actually measuring spasticity and trying to communicate that it's pretty bad spasticity and we might need some intervention. So there's that. The Tardieu scale, again, my French is terrible. I apologize about that. It measures the maximum range of motion using the slow continuous stretch. And you have to get the goniometer on them, and then you quick stretch the joint, and the measurement is the difference between the 2 range of motion numbers. I have seen this used fairly frequently in the pediatric population. I'm not able to really utilize this often by myself because it is very difficult when you get into the adult population. And that's the pros and cons. The pros, again, it's inexpensive. You need a goniometer. And it's easy to perform on children, especially small joints. And it is theoretically less subjective than the Modified Ashworth because you actually have a degree measurement. You know, that the difference between a slow stretch and a quick stretch is 22 degrees. So theoretically less subjective. The cons are it's very difficult to perform with large limbs or large individuals. Sometimes even getting an accurate goniometric measurement of end range when someone is still is difficult if they have very much adipose tissue, or it's just a very large individual with large limbs. It can be very difficult if you can't get optimal positioning. It has poor inter-rater reliability. So again, I do it great on my patients, but when we go and another clinician measures my patients, there could be some pretty significant differences. And again, it's not widely used in the adult population, I think really just because it's very difficult. Can be pretty strenuous, and you can have to repeat it a lot of times to try to get the alignment right in the adult population, or if really long extenders on your goniometer, and then again, your goniometer's accuracy is not as good. Reflex testing, we have all done just standard reflex testing, and it's really just a gross sign that they have spasticity, kind of like a upgoing toe on the Babinski. All you know is they have an upper motor neuron lesion. Functional testing, this is where you get to say how the patient's really doing in real life, and it's individualized for each patient. What you choose is appropriate to your patient, so there really aren't standardized measurement tools. Obviously, gait speed is nice and standardized. It's nice and quick. A timed up and go, a dynamic gait index. But again, if you have a patient that's not ambulatory, those aren't going to be functional. So you can use the FIM, you can use the Wolf upper motor function. You just kind of have to find what works for that individual patient to measure if they're showing an improvement or a decline, so you can measure that accurately. Okay, case study number 1 is this 52-year-old female. She was diagnosed in 2002, so it's a fairly recent diagnosis. We took these videos about 6-8 months ago, something like that. She was living at home prior to this last relapse. Since then, she's required in-home assistance almost 24 hours a day. She has become wheelchair-bound. Because of her incontinence, she and her caregivers chose an indwelling Foley catheter for neurogenic bladder management. That's a whole nother lecture. We'll talk about that later. She does have pretty severe short-term memory deficits at this point, and she was seen on the day of the trial for an intrathecal baclofen, or the day of the video for an intrathecal baclofen trial. Her goals are pretty basic. Her daughters had to move in with her, and she has an 18-month-old. So, you know, it would be great if this patient could care for herself a little bit more. So goals are for transfers with only minimal assistance, to be able to help bathe herself, to work on hygiene, dressing, you know, pretty low-level things that could help her family out a lot as far as function goes. So here we go. Let me get the video up. And as this is loading, I want to say this is the best position I could get her in. I even had someone there helping me, then they kind of backed off to video, but this patient was extremely difficult to get positioned.
You just relax and let me move your legs.
So now you can see this is maximum range there, and then there's a quick stretch. That's as far as I can get her. Yep, and I thought, okay, maybe if I take both legs, you know, I can get a little bit more.
Okay.
And that's it. Also, in this video, I'll play it again so you can watch.
You just relax and let me move your legs.
And we'll see a little bit later, but she is also a 4. She's rigid as far as her adduction goes, that I can't get her knees apart without somebody else helping stabilize her. And her hip flexion is also rigid in this position. So yeah, transfers are really hard. ADLs are really hard for her. This is just spasticity to the point that she's pretty much not functional. The good news at this point is she was free from skin breakdown. So here's treatment options for this patient that we could try. We could try oral medications that act on the CNS, so oral baclofen, oral Xanaflex, Valium. We could try some physical modalities: heat, stretching, strengthening, e-stim, and exercise. Those are all options. But if we go to medications, most of them are sedating and can cause short-term memory problems. She already has short-term memory problems. And also, she's already on the maximum dose to Xanaflex approved by the FDA. And they all have to pass through the blood-brain barrier to be effective. But a lot of times, they're kind of the first line of treatment and management with spasticity. They're easy, they're generic, they're inexpensive. And they all pretty much have equal effectiveness. So, you know, if one doesn't work or a patient doesn't tolerate one, sometimes they'll tolerate the other one a little bit better. Physical modalities, unfortunately the effects of physical modalities and what we do in the clinic is pretty transient. So the studies have shown no significant improvements on range of motion with manual stretching protocols, which, you know, we kind of know that already. There's no improvement in gait parameters with manual stretching programs. We've known that for quite a while as well, that stretching for 15 or 20 minutes a day just isn't enough with these patients. So it really works best in conjunction with medications or some other intervention. But they can help prevent some of the secondary effects as far as pain relief and mostly pain relief, but for short periods of time they can help patients get up and go. Other medications, Botox injections, which is an ACH inhibitor, and really for it to work well it needs to be done with an EMG technique to ensure that the most important motor units are being targeted. So you can only get so much and you want to make sure it's going in the right place. The good news is if it works, it lasts 12 to 16 weeks and you can get more, and if they don't like it, it wears off in 12 to 16 weeks, but it is every 12 to 16 weeks. And there have been some studies shown that with repeated long-term use you can get more nerve sprouting of those little motor unit ends that as they sprout out, because the Botox kills them off and then they regrow, and you can get more sprouting with long-term use, so you do have to have higher doses, and you can get up to FDA and body weight issues with the Botox. Surgical interventions for this patient. Dorsal rhizotomies aren't done that much in the adult population. They were done most often in children with CP, where they just went in and they did laminectomies all the way down, took the dorsal, clipped the dorsal roots out all the way down to help decrease that sensory reflex loop, because sensory feedback couldn't get in, so the thought was then spasticity couldn't get out. There's very mixed reviews on this long term. I think the jury's still out as these children grow into adulthood, how effective it really was long term. Tendon lengthenings can be done. You can see this patient really tight hamstrings, really tight adductors, so they could go in and they could clip those and lengthen them out so that we can get our legs longer. You know, it's little and short and we clip it, you know, it's like this, and you clip the tendon and then we can straighten it out. Now, that does make the tendon longer, it does make the limb stretch out, does not treat the actual spasticity. That muscle is still disinhibited. It's still working overtime, so it may have to be repeated. It also can cause some changes in that length tension relationship with the muscle. So gait can change, muscle strength can change, power can change, so you have to kind of be prepared for those types of things. Intrathecal baclofen pump is a surgical implant of the drug, so that there's a pump actually implanted. I should have brought one, but we're doing another lecture on that soon, so you can come back. And the pump is actually implanted into the patient, so then they get baclofen administered directly into the intrathecal space. The specific weight of the medication is, someone is sending me a link for Google, so I don't know, distraction. Anyway, the intrathecal baclofen pump is administered, the drug is administered into the intrathecal space. And because the medication is a liquid, but it's heavier than the CSF, it flows down the spinal cord. So wherever you put the medication in, it primarily affects only the nerve roots below and the spinal cord below that level. And it can be programmed to increase function or change at different times of the day. So if the patient's more stiff in the morning, they can have a little bit more right before they get up in the day. If they want more before they go to bed so they can sleep, they can have a little bit more then, which is really nice. So it doesn't have to be a straight continuous dose all 24 hours. Pros and cons of ITB therapy. The pros are, it decreases the medication dose. It goes from a milligram dose to a microgram dose, so sedation is much less, also because it's not being administered into the brain. It can increase function quite nicely, and there's starting to be more research on this, but it can increase function more than it has previously been thought to. It's the ability to modify the dose as the condition changes is really important with MS. If patients have an exacerbation, then we can temporarily change the dose. If that needs to remain permanent, we can leave the dose there. Again, if the patient says, okay, I am really spastic after lunch when I need to use the restroom, and about 30 minutes after that, I really can't walk. So they can have just a little tweak for the hour and a half or so around lunch to keep them loose then. And like for the patient that we saw earlier, it removes the need to remember oral medication. So our patients that are having memory problems, this also works really well. Their caregivers, it's one less medication for them to remember. So all of those things are real pluses. And there are some payment advantages we found because it's refilled in the doctor's office as a procedure. It doesn't count as far as the number of medicines that they're getting. So some of the state insurance plans, Medicaid type plans, there's a limit of how many oral medications they can have. Once this is done as a refill in the physician's office as a procedure, sometimes it knocks it off of the list so the patients can have opportunity to have another medication that they need. Cons are, this is a surgical procedure, and it's a decent sized surgical procedure to get the pump implanted, so you have all of the rehab and recovery after a surgical procedure. It requires monitoring and adjustment by the physician, especially in that first 3 to 6 months when the patient's getting used to it and getting over the surgery. It's a visit about every 2 to 3 weeks for the first couple months. If the pump malfunctions, which doesn't happen often, but it's always a risk, if the pump malfunctions, the patients can go into withdrawals. So they need to have a wallet card. They need to know what to do in case that happens. That's a big deal. Sudden withdrawal from baclofen is a big risk for seizures, so we don't want that to happen. And this is a long-term commitment for patients and caregivers. The pump lasts for 7 years, so it's a 7-year commitment. So you don't want to jump into this with a flighty patient that, I think I might want it today, but I might not want it tomorrow. I just want to, can I get the surgery and then see how it goes? Those are not good candidates. This is a big commitment to come to doctor's appointments, be there on time. You can't miss them. So you want to make sure you have the right patient picked out for it. This is 2 hours after this patient had a trial of baclofen, so I helped with the positioning. She had some intrathecal baclofen injected directly into the intrathecal space by the physician. I think this was a 100 microgram dose for her, and this is and this is 2 hours afterwards, so this is getting close, not quite peak. Okay, like I said, this is not peak effectiveness, but getting much better. And you can see she's not getting all her range, but better. Relax. This is much better. Much better. There was none of that happening before in the exam room where you saw it. And I'll show you again. I want you to note she has both. She has spasticity, but she also has a hamstring contracture. So I still cannot get her knees into full extension, and that's just good old-fashioned. So that's her full active. She does have active range now she didn't have before, and that's it. So she's still lacking, around 30 degrees, which is not great, but there really wasn't an option to try to do any splinting or anything before that. But this abduction that she has now for hygiene, that's huge, because bathing her was like a half a day ordeal. So that for both she and her caregivers is a huge improvement. Okay, injection. So 2 hours later, this was wearing off. So it was just kind of a quick trial to see what would happen if she had it. So this is the same patient. We did refer her for the intrathecal baclofen pump placement, and she had it placed a couple months later. And she then went to inpatient rehab, and then they also fitted her with dynasplints for the knee contractures. And then she went home with home health. And unfortunately, I do not have, I'll back up so you don't have to read that. I don't have like a long-term video of her. She came on a day I wasn't in the office. But she reports from her daughter, she is transferring herself. She watches herself completely in the shower. And she does she can't get her pants over her hips, but she does the majority of her lower body dressing and all of her upper body dressing by herself. And she is using a power chair in the home now. So overall, her function, she's a lot more independent. So we're getting there. She's getting there. And it's been about 7 months since she had her pump placed. So pretty recently. So what do you do with somebody with spasticity? And again, if you guys have questions, type them in here. So I will try to get the... So what do I do with a person with spasticity? Obviously, treat the person. Spasticity is part of what they're coming with. It's part of their suitcase of symptoms that they come with. So you have to look at the whole person, just like you always do with every other evaluation that you see. And you want to evaluate function. How much of their activity is positively affected by spasticity? And what parts are hindered by spasticity? We see a lot of patients that stand up very straight on just a little bit of plantar flexion and a little bit of quadriceps spasticity. And if you take that away with too much baclofen, then they can't stand up when they want to get out of a chair or after they use the restroom. So sometimes a little bit of spasticity helps, especially if they've had it for a long, long time and they're used to it. Children with CP, people who've walked around with incomplete spinal cord injuries, or patients with MS where like spasticity gradually came on, they like a little bit. They don't like to be able to completely relax, because then they can't move their muscles. They're too weak with underlying weakness. But then spasticity can also get in the way, like the lady that we just saw that was really hindered by her inability to move. Look for other underlying movement problems that are masked by spasticity. Are there movements that are grossly linked to whole limb patterns? So sometimes a patient has, if their arm is moved very suddenly, their lower leg will go into a spasm or some type of tone pattern. So if there's other movement problems that are linked that set off their spasticity or that they're compensating with, you need to pick those up. We see a lot of patients too that will extend their neck really hard because it'll kick in the spasticity in their lower legs, and then they can stand up and move a little bit better. So you want to kind of look for what the patient's cheating with and see, is that a good cheat? Is that a bad cheat? Is that a cheat that's causing them more problems? Like I'll see, I have one patient came in for chronic neck pain. To stand up, she was doing that to kick in the spasticity in her lower legs. Well, her neck pain is also related to her spasticity and trying to get them to move. Okay, thank you. Keith sent us the... it's not copyrighted or anything yet. You can use it for free, so don't worry about that. Okay, so anyway, getting back to this. So you really want to look at other underlying movement problems that are masked or helped by the spasticity. Sometimes we have some patients that do, so once you take their spasticity away, they've got some pretty funky stuff going on. So look for that. Also, orthopedic problems. Spasticity you end up with a lot of other orthopedic problems on the leg that's not affected by the stroke or not affected by MS. So they'll move their quote-unquote good leg in very odd ways to compensate for that spasticity. And they'll have a lot of pain in their good non-spastic leg because of all the compensation that they do. Okay, so another big part about spasticity management is you need to be part of a team, because you really, as a therapist, can't take this on by itself. There's nothing we can do as therapists to change the reflex arc. There's long term. There's nothing we can do to change the amount of GABA in a person's nervous system. So this is a problem on a physiological cellular level, and we're kind of treating the manifestation of it. So it's really important to have, first of all, the patient on board with whatever the plan is. You know, do nothing is often the best plan, and the patient needs to be on board with that if that's the best plan. The PCP, especially if you're in more rural areas, the PCP is kind of your go-to person for almost everything. Neurologist or physiatrist, if you have those in the patient's team, are great resources to help with this as well. Other therapists, the speech therapist, if there's swallowing problems involved or postural problems involved, the caregivers, by golly, if there's caregivers, pick their brains about what life is like at home and what function is really like at home, because all of the time the patient is telling me one thing, and then the caregiver's going, no, it's not like that at all. So you do kind of have to get a gauge on what's really going on at home. I envy home health therapists often because they really get to see it. I just get this little snapshot. And then what part does each team member address most effectively? Obviously, I as the therapist am not going to change anyone's prescriptions. I'm not going to change their medications. However, if this is a problem, I can help the patient communicate back to their physician. Their spasticity really is a problem. Until that changes, their walking is not going to get any better. Until this patient that we saw first, until she can get her legs apart for bathing and hygiene and self-care, we're going to have to keep an indwelling Foley. We can't look at her being able to self-cath by herself. So, being able to really help the patient communicate what parts of their function are impacted by spasticity is really an important job for the therapist. And then also, empowering the patients too, that it's okay to talk to their physician. It's okay to have a list of questions when they go in. And these are some of the words that your doctor might use as far as when they're talking about your legs. These are the fancy sounding words that they might be using. And then who is going to oversee and help manage this team? Is it going to be the home health nurse or the Advantage case manager if your patients are on Medicaid and have Advantage? Are you going to be seeing the patient every so often? Is it the PCP? Or are they going to see a neurologist every 6 months? How is this someone going to keep tabs on how this patient is doing? And that's, I'm very spoiled. Our clinic is interdisciplinary and the physicians are right here, but even in working with other clinicians a distance away or patients that travel from other states, it's really important to kind of hash out some of these questions before you start changing anything. It's one of those things where an ounce of prevention is worth a pound of cure, so nobody's confused. The patient knows what's going on. You know what is going on. The PCP knows what's happening. The neurologist knows what's happening. So sometimes it's a lot of faxing, or if you have secure email, a lot of emails back and forth, but it pays off in the long run. To not have patients confused, to not have patients taking the wrong medications, and to have the patients doing the right therapy at the right time. Okay, what do you need to be on a team? Obviously, some of these, I love insurance, this, who that tells me when I can see my patients. But therapists see their patients more frequently often, and you can often evaluate if a medication's effective. They go to the doctor on Tuesday, they start their new dose on Wednesday, they come to you on Friday. So is it better than it was last week? Is it the same? Is it worse? You can really help evaluate that. Also, helping the patient evaluate and yourself evaluate the expectations of a medication. If you're going to start taking Xanaflex or Valium, yes, your spasticity will be better, but you're also going to be sleepy. So is it worth the trade-off when you come to therapy and you keep falling asleep in the middle of OT or speech therapy? It may not be worth the trade-off. So evaluating those expectations and if they're met or not. Or if a tendon lengthening is worth it or not. Is it worth it to be non-weight-bearing in a cast for 6 to 8 weeks? Or are the trade-offs for immobility, pressure sores, those kinds of things too great? So kind of helping the patients hash that out and hash it out with their physicians. And also, no one intervention or treatment is going to cure spasticity. It's not going to cure the underlying neurological condition. These are lifelong problems these patients deal with. So we do baclofen pump trials here. We do Botox injections, and I try to be very, very clear with patients. We are not curing their MS. We are helping manage one symptom of their disease. We're managing one part of their spasticity. It's not even curing their spasticity, it's just managing the symptom of it so they can function better. With upper motor neuron damage at this point, there's not a cure. So being very, very clear with the patients on that this is not a cure for their disease or their syndrome or symptom or whatever type of problem that they're having. This is only managing the symptoms. Okay, challenging time. This all is extraordinarily time consuming. As my time is running out as well, you have very limited therapy visits. Yeah, it's extraordinarily time consuming. Team management takes way more time and nobody gets paid for it. The doctors don't, we don't, the nurses don't, nobody does. You just kind of have to love it out of the goodness of your heart. And also research about improving function in MS with spasticity is very, very lacking. So if you try to send patients or physicians to the literature, it's just really not there. It's really, really lacking. So for any of you out there that are doing research or involved in clinical research at all, it's wide open, wide open. So there's that. And also, many things increase spasticity and decrease function. Bladder infections, pressure sores, infections, full bowel, full bladder, stress, dehydration, overheating, ambient temperatures, fatigue. So if spasticity's gone up and the medication isn't changed and spasticity's going up and down and up and down, those are some other things to look at, like, what's your urine look like? When's the last time you had a bowel movement? How much water are you drinking? How hot are you? Check people for pressure sores. Those are easy things to do that if you can help fix those, help manage those, their spasticity is going to go down. They're going to be more comfortable and probably more healthy in the long run, because those are all pretty bad things as far as health goes. Okay, last case study real quick. This is a 50-year-old gentleman. You can see he's had MS for a while. His goal is to be able to walk at work and at home without falling more than once per week. At this time, he's got lesions everywhere, lives with his wife. He has lesions everywhere, and he falls at least once a day. So here we go. I have 2 videos of this gentleman, so we'll kind of watch both of them, and please post questions. And it's always hard to videotape people with walkers because are you in front, are you in back? They need their walker, but you can kind of see his hip movement here. Okay, and then we'll watch that one more time just since we're and this is real time, so we're not moving any too fast. This is pretty slow. This is also first thing in the morning, so he's looking pretty good.
All right,
okay, I will pull up this next one.
right there.
Okay, and here you can see a sit to stand a little in the back. And again, pardon me, I have the token hand on the belt loop. I realize when I look in video, there's always the token hand on the belt loop. So you can see his walking isn't terrible, especially with the walker. It's really not that bad. Whoop, there's a little hiccup. Let me see if I can get you just so you can see a little bit closer, and then you can get to his hiccup. There you go, and you can see as he gets a little bit farther into it, he does have one of those little unexpected hiccups. Right there. You can see it kind of gets in his way a little bit. So that okay, so there he is. He does use stuff going on. These are pictures of the videos. So questions to ask when you see this guy. And this is the hard part. I haven't ever done this in this format before, so you guys let me know. Again, questions. Is spasticity limiting this gentleman's function? Yes and no. I mean, we saw his foot when I did the modified Ashworth on him in the very beginning. He is spastic. How much is it limiting his function? He's walking short distances, not too bad. He is still having quite a few falls, though. Are you hearing me, Kelly?
No, we lost you.
Oh, no. Am I there again?
Okay, you're back.
Okay, I'm back. Sorry, I got lost for a minute. So how much is spasticity limiting this gentleman's function? He can walk, but he still falls. He's... So moderately, he is able to walk safely, sort of, some of the time, but he is having these falls every day. So, yeah, it is getting in his way. Are his goals attainable to be able to keep working part-time, be able to walk around at work safely? Yeah, I think highly likely. I mean, he's walking pretty well. He's motivated. He continues to be active, continues to walk. So, yeah, I think his goals are pretty attainable. Who needs to be on the team, though, with this guy? The patient, the wife, the neurologist / physiatrist, if he has one, the PCP, and the PT. This gentleman is a candidate for oral medications at this point, and that's what he chose. He didn't want to do any surgeries. He didn't want to look at Botox injections. He just wanted to try some oral medications. He has had okay success with them. They do make him drowsy, so he can't take them if he's going to drive. So that's kind of his, little issue there, that if he's just going to be walking around at home, he's awake enough, but if he needs to drive, then he can't take him. But worked with this guy a lot, and his wife, and I follow up with him about once a month just to make sure everything's going okay and nothing's changing with him. And what was the role for each team member? Well, obviously the patient and his wife, they're the ones that have to go home with the treatment plan at the end of the day. He is currently seeing a physical therapist closer to his home, and I think he's just about to be discharged. He was going about twice a week. He also has a home exercise program, and goes swimming in the pool once it opens, so he's very aggressive and very good about doing his home maintenance program and staying strong and doing all of those types of things. His PCP was also involved just to make sure with all of his other medications and other issues that adding another medication was going to be okay. And then he is followed by his neurologist once every 6 months. So he has a lot of appointments. He has a lot going on, which for him is okay. And again, he preferred kind of just oral medication. The other thing about oral medication is he's on a very low dose. He can add a little more when he needs it. He can take a little bit away when he doesn't need it, when he's going to drive. So for him, that worked really well. Excuse me, I'm sitting on my cord. There we go. Okay, so that worked really, really well for him, and so far so good. His falls are down to about 2 a month, mostly I think because he's been going to his PT and he's gotten so strong. So he's doing great. So this is a patient really on the lower end. We saw the patient that was on the high end of spasticity, needed a lot of intervention, ended up going full on baclofen pump. And this is a gentleman that opted for a much less invasive option, which is there as well. And again, both patients' therapy was completely appropriate at the right time, and the therapist had to be there at the right time, at the right place to make sure that they maximize their potential. This is not something that medication or therapy alone will be able to fix. This is really truly where healthcare has an opportunity to integrate and really benefit the patient for their maximum function and to keep them functional as long as possible. So this is about my... Sorry, you get to animate these again. There you go. So kind of in wrap-up, we have a few minutes left, and I'll stay on for questions for another 10 or 15 minutes if anybody has them. Spasticity is a velocity-dependent response due to muscle or tendon stretch that it impacts individuals only with upper motor neuron damage. It can be measured with the MAS, the Tardo reflex testing. Treatments include medication, surgical procedures, and therapy. And therapists should work to really be part of a team to address all the aspects of the spasticity and function over the long term. And that's it. These are references, and so feel free to print those out or go back to those again for any that you would like. Also, my email is on the first page, so if you would like to email me at any time, and okay, the question, can you see the questions, Kelly? Yes. Okay, so everyone's seeing this question about the employer supervisor being on the team. Yes, definitely. If the patient is falling at work and he's having difficulty at work, there needs to be an employment plan. This gentleman works for I'm trying not to give too much away here with HIPAA. He works for the state of Oklahoma in a department that is very, very amenable to whatever he needs. So pretty much, if we wrote it, the doctor wrote it, it was going to happen at his workplace. So they actually moved his office a little bit so it was closer to the bathroom, and then a little bit was a pride issue with the patient because he wasn't wanting to take his walker in, we discovered, to work. So now he takes his walker into work and is contemplating getting a work walker just to stay there so he doesn't have to take it back and forth. But that's an excellent question. And Department of Rehab Services here in Oklahoma, and I don't remember, is it Texas Rehab Commission, TRC, is it TRC in Texas? They're great to have as partners and have our patients with MS have open cases to keep them working and get what they need at work. So that is an excellent question. And I guess that also goes to a legal question too, if, what's a reasonable adaptation, a reasonable modification at work too. Again, that may be a whole nother day. So. I think my favorite thing though is when bosses call and ask what they can do to help the patients at work. That's like great gravy for me. And I guess I've had a few questions, not here, but I've had some questions in the past and from students as well about how do you get this paid for? And it really is tricky because you do spend a lot of time at the fax machine and a lot of time on the phone. With physicians, often it's best, I've discovered, if you can have a set time that it's just like calling in for especially if you don't have secure email with them, that this is my appointment time to call in and talk about this patient with you, so that there's not too much back and forth and there's not too much time wasted with that. Obviously, progress notes, we're all used to faxing those. In case you can't see it, there's another question about vestibular and balance testing done. TRC, sorry, back to the first question. TRC changed their name, Texas Department of Assistive and Rehabilitation Services. That's a better name anyway. I'm glad they changed. Yay, thank you for that. Vestibular balance testing done and assistive devices for this gentleman. His vestibular system, this is a really tricky question, Keith. He does have bilateral central vestibular hypofunction. He, at this time, does not have an INO, which, for those of you that don't know, an INO is when one eye goes really fast and then the other eye follows along. So it's like, and his eyes were tracking, I can't even do it with my fingers, tracking pretty well at the same time. And so I didn't mess with his vestibular system too much because he had accommodated really well. He was really stable. He wasn't having dizziness or floating or sensations. He wasn't nauseated. He didn't have double vision or blurring when he turned. I know that there was underlying vestibular dysfunction there because of where his lesions were on his MRI, but I just kind of let that sleeping dog lie because it really wasn't what was impacting his function. A lot of times vestibular function with MS, it is what's impacting their function and causing falls on top of the spasticity, so you do kind of have to parse that out. This gentleman, I don't know if you noticed the little nuggets that were on the side of his ankles. We were doing a Bioness trial with him too, and he has rented one Bioness unit for one side and is toying with possibly buying it and possibly getting one for the other side because they do help him counteract that spasticity and get more dorsiflexion when he's tired or when he wants to walk outdoors. It's more gadgets, so he and his wife are kind of tossing around the idea about how bionic does he want to be by the time he has a walker, a scooter, 2 Bioness units, just how much is too much of a good thing as far as technology goes. And he, in therapy, I got a progress note from him not too long ago, was able to do a little bit of walking with loft strand or forearm crutches a little bit, but wasn't safe enough to really go out and just take off with those. Are we able to review or save your slides for references? I don't know. That's a mobility question. Can they get back in and look at the references? So I encourage everyone, if you work with MS, people with upper motor neuron lesions, I encourage you to start measuring spasticity, both from a functional standpoint with gait speed, FIM, something. Dynamic AFOs, that's a really good question. Terrence is asking about has anyone tried dynamic AFOs for ambulation? Yes, I've tried everything. I will put it out there. If it comes on the market and I think it might help, I will try it with a patient and see what happens. I have had mixed reviews with the dynamic AFOs. Sometimes if it's not a whole lot of spring, so it doesn't really set them off, or it sets off enough of a flexor kind of a retraction reflex, so they're actually it causes them to flex more. So instead of when it springs, their leg actually pulls up at the hip and the knee a little bit. You know, sometimes that's okay. The weight of the dynamic AFOs is often a huge perk, that they're a lot of them are carbon fiber or kind of a mixed material. They're light, they're easy to get on and off. The patients love them. They're not hot. There's not a lot of skin contact. So it's a balancing act. I probably have 60 to 70% of my patients that have AFOs have some kind of mixed medium dynamic AFO, because the weight is so amazing. Like I have put a custom like diabetic foot orthotic over the foot plate, and that helps cushion the spring a little bit, so it turns into a little bit more of a posterior leaf or just an anterior shell. But again, I'm gaining so much by having that carbon fiber as far as decreasing the weight of the limb, that I go for it, and the patients will wear it. It doesn't do me any good to get them a really expensive custom plastic formed AFO if it sits in the closet and they won't wear it because it's too hot and it's too heavy. So I do use them a lot. So and again, that reminds me, I neglected to put orthotist as a person on the team, but orthotists a good orthotist is invaluable. If the patients are diabetic, those inserts are paid for by Medicare and insurance. If they're not diabetic, some of the orthotists will really work with the patients on price, and there's different materials, so the expense can go up or down depending on what materials they're using. So, you know, if you need references for an orthotist, I'll be happy to put you in contact with mine that usually can help you find someone else in your area. So, yeah, I love the Windows Dynamic AFOs, and I know a lot of people are anti because they're not custom and as customized, but I love them for a lot of patients. Okay, well, I'm going to kind of wrap up, and again, feel free to email me at any time. The email is always open. Yes, Hanger in Tulsa works well for dynamic AFOs. I use Hanger here. I use OrthoCare here. Hanger's nationwide, so you usually can find a Hanger person somewhere on the North American continent. But if there's not a Hanger locally and you want someone else, the orthotists I work with here have been great about finding people in, you know, the sticks of, you know, Arizona and things like that for us. So, you know, I will be happy to help you with that as much as possible. But anyway, that's it. So feel free to email me. You guys have the PDF, and I guess we're doing another one of these next week. So thanks for tuning in.